Hi, my name is Ginjal, and today I'm going to be presenting about adenosine with my group members Rita, Aaron, and Zoe. To broaden the pharmacological context of adenosine, it is a purine nucleoside where adenine binds covalently to a ribose via a beta and 9 glycosidic bond. It forms from the breakdown of adenosine triphosphate, or ATP, which, as we know, is essential as the primary energy carrier in all living organisms. Most ATP is hydrolyzed to adenosine diphosphate, ADP, which can be further dephosphorylated into adenosine monophosphate, or AMP. The way that ADP and AMP generally forms in the cell is through rephosphorylation by the mitochondria, which is facilitated through a series of reactions requiring the presence of oxygen. Therefore, if there is insufficient oxygen available, such as in the event of hypoxia, and large amounts of ATP are being hydrolyzed, the 5' nucleotidase enzyme can actually dephosphorylate some of the AMP into adenosine. As for some properties of the compound, it is small, polar, and hydrophilic. So for example, we know that adenosine enacts its effects into the central nervous system, but because of these properties, it cannot freely diffuse across the blood-brain barrier as it is, but instead it'll gain its permeability through adenosine receptor signaling, which is expressed on cells of the blood-brain barrier. Additionally, in terms of protein binding, not much is known about that, but we do know that it binds to albumin. Adenosine can also bind to different receptors to enable coronary vascular smooth muscle relaxation, which is vasodilation, and promote blood flow by binding to 2A receptors, which are coupled to G proteins, which stimulates adenylyl cyclase to catalyze ATP into CAMP. So increasing CAMP can cause vasodilation through decreasing phosphorylation of myosin, which decreases contractile force. And then increasing CAMP will also activate protein kinases and trigger the potassium ATP channels, or KATP, hyperpolarizing the muscle and causing relaxation. There's also additional evidence to indicate that vasodilation could occur through increases in cGMP, which leads to inhibition of calcium entry in cells. Through this effect, adenosine can also be used for myocardial perfusion imaging, which is known as a stress test, which is when your coronary arteries will be dilated, and that simulates the effects of exercise on the human body. And the medical team will monitor your blood pressure and cardiogram.
Supraventricular tachycardia, known as SVT, occurs when the patient's heartbeat is erratic and irregularly fast. A typical heartbeat is between 60 to 100 beats per minute, but someone experiencing tachycardia will have a heart rate greater than 100 beats per minute. Most SVT episodes will actually be between 150 to 220 beats per minute. A heart rate in a healthy individual occurs in 4 steps. We have the signal that starts from the sinoatrial node, known as the SA node. And when this signal is released from the SA node, it will travel to the atrium and cause contraction, causing the atria to pump blood into the ventricles. The signal will then continue its way through the heart, reaching the atrioventricular node. Here it will pause briefly, and this pause will allow for ventricles to fill up with blood. Eventually, the signal will continue its way through, leading ventricles to contract and pump blood to the rest of the body and the lungs. In an individual with SVT, there's actually faulty electrical signaling that occurs and causes atrium to beat too early. As a result, the blood isn't able to fill up the heart completely, and this results in not enough oxygen and blood being pumped to other organs like the brain.
So now about the pharmacokinetics of adenosine. Adenosine may be administered intracardiacally or intravenously, but for the purpose of this presentation, we'll focus on IV as it's the most common route. IV is preferred as it provides optimal access to adenosine's site of action as a cardiac medication in the safest way. Administering the dose intravenously has shown to slow the conduction through the atrioventricular node, which interrupts re-entry circuits involving this node. This allows the restoration of a normal sinus rhythm in patients with paroxysmal SVT. Depending on its intended use, the dose will differ. For example, to manage SVT, adenosine is initially given as a 6 mg dose with 20 milliliter saline flush to encourage a faster infusion. Then the dose is doubled. In the case of patients who have had a heart transplant or who are on other medications like dipyridamole or carbamazepine, the dose is lowered to a 3 mg bolus, which is a single large dose, if it is administered through an IV line with direct access to the central circulation. For cardiac stress testing, IV is also the preferred route, but in a continuous fashion rather than a bolus approach. In this case, the dose is based on the patient's weight. And so due to all the influencing factors for dosing, adenosine is exclusively a prescription drug, which is why it requires a medical professional to administer it. So about the absorption and the distribution, because this medication is administered intravenously, it actually bypasses the absorption phase and directly enters the bloodstream to be distributed. The injected dose goes through rapid uptake by erythrocytes and vascular endothelial cells. It has an onset of between 20 and 30 seconds. Adenosine has two main metabolism pathways. First, adenosine may be phosphorylated by adenosine kinase to form adenosine monophosphate. It can then be phosphorylated again by adenylate kinase 1 to form adenosine diphosphate. From there, nucleoside diphosphate kinase A or B can form adenosine triphosphate, otherwise known as ATP. This pathway, thus, translates into cellular energy. On the other hand, adenosine can be deaminated by adenosine deaminase to form inosine, which can then be phosphorylated into hypoxanthine by purine nucleoside phosphorylase. Xanthine dehydrogenase can then oxidize hypoxanthine to 2 times to form the metabolites xanthine and finally uric acid. So then adenosine will be eliminated through the urine as uric acid. In all, adenosine's half-life in the blood is about 10 seconds. In general, adenosine doesn't seem to have a severe or serious interaction with other drugs, but moderate and mild interactions have been noted. For example, green tea and nicotine have been shown to moderately interact with adenosine, while caffeine interacts mildly. So it is recommended to avoid caffeine when taking this medication, as caffeine may act as an antagonist for the activity of adenosine. And as mentioned earlier, doses may be adjusted to the patient's weight and other health factors. And finally, it's important to note that pregnancy is not a deterrent for the administration of adenosine, but we will talk more about interactions a little bit later in the presentation as well.
Now we'll look at pharmacodynamics. There are 4 evolutionarily well-conserved G-protein coupled adenosine receptors, which are A1, A2A, A2B, and A3. These receptors are ubiquitously expressed, and they are found throughout the body, meaning that they have effect on multiple different organs, tissues, and systems. They play a major role in controlling the coronary circulation of the body, and we'll spend most of our attention looking at this. In terms of using adenosine to treat SVT, the A1 receptors are the most important since these receptors are found in the AV node, and they mediate negative chronotropic effects, which means they decrease sinus rate, as well as they cause negative dromotropic effects, which means a decrease in AV node conduction. Additionally, A2A and A2B also have an impact since they produce vasodilation in most vascular beds, and since these 2 receptors are the only ones out of the 4 found in coronary endothelial cells, their bonding with adenosine leads to increased myocardial blood flow. That also helps return the heart rate and the body back to normal. So if we look closely at how adenosine bonding with A1 affects the system, here we have our A1 receptor right here. And when it binds with adenosine, we have a conformational change that allows it to interact with the GI protein and activate it. The GI protein then inhibits adenylyl cyclase. Now, usually, adenylyl cyclase will convert ATP into CAMP, which interacts with kinases and leads to the phosphorylation of calcium-gated ion channels. In a phosphorylated state, the calcium can then enter through the channel since the channel will be open. However, since GI inhibits this pathway, without phosphorylation of these channels, calcium will not be able to enter the cell. Additionally, the conformational change also leads to interaction with the GO protein, which, once activated by the A1 receptor, will lead to increased activity of potassium-gated ion channels, resulting in more potassium being transported out of the cell. This leads to hyperpolarization that causes a delay in signaling and helps return the heart rate back to normal. Adenosine has many therapeutic effects, such as decrease in heart rate, but it also has toxic effects since these receptors are ubiquitously expressed and found everywhere in the body. Thankfully, these toxic effects don't last very long because of the half-life being only 10 seconds, but this also means most therapeutic effects also do not last very long because of this half-life. So if we look at some of these adverse effects, most of them aren't too severe, such as flushing, headache, nausea, vomiting, but more severe ones such as AV block, which occurs when the atrioventricular node is completely or partially blocked. We can see arrhythmias, which is another type of irregular pattern in the heart rate that's caused by shortening of the atrial action potential, as well as adenosine-induced bradycardia. We can see bronchoconstriction since there are receptors in the lungs. And finally, sometimes we see asymptotically, which is when the patient flatlines, shown over here. Finally, it's important to mention some adenosine interactions. So we have synergists, which all decrease the heart rate, and some of these include cardioactive drugs such as digoxin and verapamil, as well as we have antagonists, which would increase the heart rate and contradict the effects of adenosine, and these include mesylamphenes like caffeine and the asthma drug theophylline. Now, it's important to mention that caffeine specifically is able to increase heart rate by binding to and blocking A2A receptors.
Adenosine prolongs the lives of patients by resolving supraventricular tachycardia and by playing a role in diagnosis of other potential issues. Because the average cost of adenosine in the United States is about $79 per dose, most patients will be able to afford this as a last-ditch treatment. However, it will set them back a little bit. So far, we have discussed how adenosine can be used in a therapeutic setting. However, it's also worthwhile to consider the derivatives of adenosine. As of right now, the only adenosine derivative that has been approved for clinical use in humans is regadenosine. However, possible therapeutic applications have also been investigated for other adenosine derivatives in cancer treatment.